Welcome, everyone. My name is Christy. I'm a genetic counselor here at Ambry, and I manage our pediatric testing menu. So thanks again for joining us today for our webinar entitled Advanced Learning, a Clinical and Diagnostic Update for HHT. In this webinar, we will be exploring Hereditary Hemorrhagic Telangiectasia, or HHT. We will discuss the clinical criteria, the impact of HHT on patients and their families, as well as the utility of genetic testing. We will also be presenting recent research into the genetics of HHT, including new genes that have increased the detection rate of genetic testing panels. Ambry's manuscript entitled Mutations in ROSA1 and GDF2 Identified in Patients with Clinical Features of Hereditary Hemorrhagic Telangiectasia was recently accepted by Human Genome Variation and will soon be published online. So once again, at the end of the presentation, we will have time for questions, so please feel free to type questions at any time during the presentation. Also, if you are a genetic counselor planning to claim CEUs, please be sure to complete the survey at the end of the presentation, which will pop up automatically when you close your WebEx by the end of the day today. If you have any questions, please feel free to email us. It is now my pleasure to introduce our speakers for today. First up, we have Katie Wusick. Katie is a board-certified and licensed genetic counselor at Cincinnati Children's Hospital Medical Center. She practices pediatric and adult genetic counseling in the Hemangioma and Vascular Malformation Center and HHT Center at Cincinnati Children's. Katie is also the clinical coordinator for the University of Cincinnati and Cincinnati Children's Hospital Genetic Counseling Program. Second today, we'll have Felicia Hernandez. Dr. Hernandez received her undergraduate degree from UCLA and went on to do her PhD training in the Department of Microbiology and Molecular Genetics at UC Irvine. She conducted her postdoctoral training at the Department of Immunology and Microbial Science at the Scripps Research Institute in La Jolla, California. After her postdoctoral work, she joined Ambry as an R&D scientist in November 2012. While in R&D, she is focused on the development of diagnostic assays for the clinical lab using both next-generation sequencing and array-based technologies. And she's also a part of the variant assessment team at Ambry Genetics. So thank you again, everyone, for joining us. Katie, the floor is yours.
Thanks for the introduction, Christy. During my portion of the presentation today, I'm going to review the clinical diagnostic criteria for HHT and talk about some genetic testing strategies based on our experiences in the HHT Center at Cincinnati Children's, as well as some from the published literature. HHT was first described by Osler, Rendu, and Weber in the late 1700s to early 1800s, and the prevalence of the condition is thought to be anywhere from 1 in 5,000 to 1 in 10,000, although there are some hypotheses out there that the condition is underdiagnosed. And the major characteristics of the condition have been known for a long time. We know that HHT is a dominant condition. We know that individuals can have nosebleeds and telangiectasias, and we know that they can have a number of different visceral arteriovenous malformations, or AVMs, and telangiectasias. In the late 1980s, one of the first larger scale studies on HHT was conducted, and the purpose of that study was to describe at what ages different symptoms began. And inclusion criteria were developed for that study, which helped to form the basis of making a diagnosis of HHT. And those inclusion criteria were to have 2 of the 3 symptoms outlined in the blue box, so autosomal dominant inheritance, nosebleeds, or telangiectasia, and a well-documented visceral AVM could substitute for one of those criteria as well. Nosebleeds and telangiectasias were enough to make a diagnosis of HHT as long as the telangiectasias weren't isolated to the nose. In 2000, however, the Curacao diagnostic criteria, which are the current diagnostic criteria we use for HHT, were developed by the Scientific Advisory Board Council for Cure HHT, which is formerly the HHT Foundation International. And the Curacao criteria utilize the same symptoms as the earlier guidelines did, but they provide some additional details and interpret the diagnosis a bit differently, and we'll discuss that. And the goal of the Curacao criteria were really to prevent over or under diagnosis of HHT. The first symptom that's outlined in the criteria is epistaxis, or nosebleeds, and the new criteria outline that they should be spontaneous and recurrent. The average age of onset of nosebleeds in HHT is 12 years, but we know that as people get older, they are more likely to experience recurrent nosebleeds. So about 30% of people have an onset of nosebleeds at age 10, 80% by 20, and 90% by 30. And overall, about 95% of people with HHT will have recurrent nosebleeds. And these can lead to anemia. A study that was presented at the 2015 HHT Scientific Conference in Captiva, Florida, looked at how many nosebleeds happen in the general population, because the criteria talk about how nosebleeds should be spontaneous and recurrent, but we also know nosebleeds are common in the general population. And so this study assessed 189 people aging from 1 to 84 years and looked at their nosebleed history. And what they found is that 95% of their general population that they studied had 2 or fewer nosebleeds per month. So if you're seeing someone who has 2 nosebleeds a month or more, then that's really suspicious and could be considered to really strictly meet that diagnostic criteria for spontaneous recurrent nosebleeds. In our experience, some patients have talked about how they will have their nosebleeds are worse at one point in their life and then get better, even though they really can't explain why or don't report making any changes. So you might have to really talk to patients about what their nosebleed history is and ask if they've ever had a history of recurrent nosebleeds, even if it's not currently. And we've also noted that some of the patients tend to underreport their nosebleeds, especially if they have a relative who has had nosebleeds that are seen as worse. If they have a relative who has nosebleeds that last longer or are more frequent, then they may not report their nosebleeds as accurately. And so you may really need to ask them some detailed questions about their nosebleed history. The second symptom that's outlined in the Curacao criteria are telangiectasias. And in order to meet this criteria for a diagnosis, you really need to have multiple telangiectasias at characteristic sites. And those characteristic sites are the lips, the oral cavity, the fingers, and the nose. And telangiectasias are like nosebleeds in that they occur more frequently as a patient ages. So about 30% of patients will have telangiectasias by the time they're 20, and about 60% will have them by the time they're 40. And on the right, I have some pictures of telangiectasias. The patient at the top has one bright red pinpoint or pinprick telangiectasia in the center of her lip. She does have other telangiectasias on her tongue, but they aren't quite as noticeable or easy to pick up by camera. And then on the bottom, you can see a patient who has multiple telangiectasias, again, that are red and small on the tongue and on the lips. The same study that I mentioned on the previous slide that looked at how common nosebleeds are in the general population also looked at how common are telangiectasias in the general population. And they looked at about 151 people, ages 3 to 84. And again, they found that 95% of the population has 3 or fewer telangiectasias in the characteristic places we see for HHT, so on the hands, face, or lips. So if you're seeing a patient who has 4 or more telangiectasias, especially on those places that are characteristic, then that is really strong evidence that they could have HHT. The next symptoms that are outlined by the Curacao criteria are the different visceral lesions that can be seen in patients with HHT. About 80% of patients will have GI telangiectasia, although only about 25% of them will have symptomatic bleeding. And that usually occurs in adulthood, sometimes starting in the 5th or 6th decades. Women tend to have more bleeding than men. And the GI bleeding can result in anemia. So some patients, depending on how severe the bleeding may be dependent upon things like blood transfusions, and it can increase the mortality and morbidity associated with HHT. Anywhere from 15 to 50% of patients will have pulmonary AVMs, and these can result in symptoms like shortness of breath, fatigue, exercise intolerance, but there can also be life-threatening complications like stroke associated with these. About 30 to 70% of patients will have hepatic AVMs, although less than 10% of those will actually become symptomatic. And some of the symptoms you can see are things like high output heart failure, portal hypertension, and biliary necrosis. The other visceral lesions you can see are cerebral vascular malformations, and the most common of those are going to be AVMs, arteriovenous fistulas, and telangiectasias, but you can also see other cerebral vascular malformations, so you can see cavernous malformations, developmental venous anomalies, and vein of Galen malformations. in order to meet the Curacao criteria, really you need to have a brain AVM and not one of those other vascular malformations. And vascular malformations in the brain can cause symptoms like migraines, seizures, and stroke. There can also be AVMs in the spine, although those are rare, and they can result in symptoms like paralysis. And then the last item in the Curacao diagnostic criteria is the family history piece. And so if a person has a first-degree relative with HHT according to the Curacao criteria, then that will help them to meet the diagnostic criteria. So if someone has 3 of the diagnostic criteria, then they can be given a definite diagnosis of HHT. And each visceral lesion could count as one criteria. A diagnosis of HHT is possible or suspected if 2 criteria are present, and it's considered unlikely if fewer than 2 criteria are present. So of course the caveat here is we talked about there are some symptoms that increase with age, nosebleeds and telangiectasias, and those are also the symptoms that are easiest to identify on exam or when a person is in clinic. But children and adolescents may not yet have any nosebleeds or telangiectasias, even though they do have the condition. And it's really important to know, even at a young age, whether or not someone has HHT, because management recommendations begin at a young age. So I've just listed a few of the medical management guidelines, but these are some that apply to individuals when they're diagnosed, which would also be in childhood. So a brain MRI within the first 6 months of life or at diagnosis is recommended, with a repeat brain MRI in adulthood. And this is, of course, to screen for the cerebral vascular malformations that can be seen. And we do know there are treatments for cerebral AVMs and other vascular malformations. And so early screening is really key to allow us to hopefully improve the outcome and identify those who do have the brain vascular malformations to avoid some of the more serious complications like stroke. Another management guideline is to have a contrast echocardiogram or bubble echo at diagnosis, followed by a chest CT if that's positive. And then if testing with that original bubble echo is negative, testing occurs throughout life, typically every 5 to 10 years, with a few exceptions. So for children who have HHT, it would be important to know early on if they have the condition so that they can get the repeat screening needed for pulmonary AVMs. And again, there are treatments for pulmonary AVMs, so the goal is to screen individuals, identify who has them, and then treat those pulmonary AVMs before they cause symptoms for the patients. But individuals, because they don't always meet the Curacao criteria, either because they're children or they haven't yet had any imaging which would alert you to their visceral lesions, you really have to think about what other ways can you diagnose these individuals. And of course, that leads us to a discussion about genetic testing. And genetic testing is really helpful for the diagnosis of people who don't meet criteria for whatever reason that may be, because they're a child or because they haven't had any imaging that would tell you about any visceral lesions that they have. But in reality, it's not really needed to diagnose someone who clearly meets the Curacao criteria, because we already know based on that criteria they have HHT and we're going to manage them appropriately for that. However, it is potentially very important to do genetic testing for those families because it's important to know who does have HHT in the family and who is unaffected. And that way we can screen people only who have HHT, and for those non-affected relatives, we can say they don't need to go through the screening. And like all genetic testing, you typically need to start genetic testing with someone who has met the Curacao criteria, who has a diagnosis of HHT. This is a schematic that I know Felicia will talk about a little bit more, and my purpose of having it here is just to show you kind of where the genes that are associated with HHT fall. We know that ANG and ACVRL1 mutations account for the majority of cases of HHT, and they account for approximately the same proportion, although we know that ANG mutations are a little bit more common in North America. SMAD4 mutations account for about 1 to 2% of all HHT cases, And then we're going to talk a little bit more about GDF2 mutations and what types of symptoms we see with mutations in that gene. But overall, GDF2 seems to be a rare cause of HHT or HHT-like symptoms. And the de novo rate in general for HHT is thought to be low. So this slide is just an overall description of the genes associated with HHT. And we can see the range of symptoms with any mutation in any of the genes. But ANG mutations in general tend to have an earlier onset of nosebleeds and are more likely to have pulmonary and brain AVMs. Whereas in ACVRL1 mutations, we see a later onset of nosebleeds, and they are more likely to have hepatic AVMs. And then, of course, with mutations in SMAD4, individuals are at risk for juvenile polyposis and the GI cancer risks associated with that. So it's really important to distinguish whether or not a patient has a SMAD4 mutation, as a SMAD4 mutation would alter their management significantly. GDF2 mutations were identified in 3 different individuals suspected to have HHT that are currently published. And the symptoms are not necessarily well defined with such a small patient population, but there were some notes that the authors made about what the cutaneous vascular malformations looked like in GDF2 mutations compared to the telangiectasia seen in HHT. So they commented that the vascular malformations in GDF2 may be less concentrated on the hands and the mouth, that they may have a more similar distribution to the condition CM-AVM that I'll discuss in just a moment, and they may be somewhat larger. So I wanted to show pictures for one of the patients who is said to have the larger cutaneous vascular malformations. And you can see, if you remember back, they look a little bit slightly larger than the telangiectasias that I showed you in HHT. And in a couple of slides, I'll put those pictures side by side so that you can get a good look. I mentioned CM-AVM, and that's the Capillary Malformation Arteriovenous Malformation Syndrome. And that's a dominant condition caused by mutations in RASO1. And the main feature of that condition are capillary malformations. Patients typically have multiple capillary malformations that are either circular or oval. And although the distribution is somewhat the same as HHT, we really see them more on the face, trunk, arms, and legs, as opposed to places like the mouth, nose, lips. And they're usually small, so about 1 to 3 centimeters, and pink, but larger than telangiectasias. About 30% of patients who have CM-AVM will also have an AVM or an arteriovenous fistula, and those are usually in the skin, bone, muscle, brain, or spine. And some patients who have their AVM or AVF in the bone and soft tissue of an extremity associated with overgrowth will also meet criteria for Parkes-Weber. Parkes-Weber typically occurs as an isolated finding, however, and is not usually in association with CM-AVM. This is a picture of some capillary malformations associated with RASO1 mutations. You can see by the black arrow and the finger that's pointing at one of those on the trunk of our patient that it's a light pink. It is a little bit larger than the telangiectasias or the vascular malformations in GDF2. And then you can see several faintly on the patient's arm. Now, the capillary malformations in CM-AVM can vary significantly. So although they're typically small, pink, you can also have larger capillary malformations. They can be darker in color, and they may not be quite oval or circular. And so this slide is just showing several different capillary malformations seen in different patients with CM-AVM to give you an idea of the variety. On this slide, like I said, I just wanted to put all of those vascular malformations together. So the telangiectasia for our patient is in the right-hand corner on her lip. It's bright red and small. The cutaneous vascular malformation in GDF2 is on the left, and they show several different ones that maybe are a little bit bigger than our patient's telangiectasia. And then in the upper right is the capillary malformation associated with RASO1. So you can see that there are some slight differences between how these cutaneous vascular malformations look. And I think it's important to know when you're thinking about, does this patient meet the Curacao diagnostic criteria, what type of vascular malformation are you really looking at? Because that will help you decide whether or not that specific malformation is associated with the Curacao criteria or not. In general, it used to be thought that sequencing ANG and ACVRL1 identified about 75% of patients who had HHT, and then when del-dup was added, that you picked up about 10% more. And then SMAD4, like I said, accounts for a small percent of patients with HHT, about 1 to 2%. And then depending on how you feel about GDF2, that probably accounts for less than 1% of patients with HHT or HHT-like phenotype. And so this gene is new, so it's possible we may identify more patients with GDF2 mutations as time goes by. But what these numbers mean is that in about 15% of patients with HHT, there is no mutation identified. And this is really difficult for people who have families and their family members are wanting to know if they are affected or not and whether or not they need to follow those management guidelines. And so the thought really is anyone who is at 50% risk should follow the screening guidelines until we can prove that they don't have HHT. So of course our goal with these families is just always to try and identify a mutation in as many cases as possible so that the appropriate patients can be screened. So when an individual meets strict Curacao criteria, so the recurrent spontaneous nosebleeds, those multiple telangiectasias at multiple sites, and has well-documented visceral lesions, there has been a study from the University of Utah that looked at about 141 individuals who did meet the strict criteria. And when they looked at ANG and ACVRL1 sequencing and del-dup, they found in their population, they found mutations in 96% of patients, so higher than what has previously been reported. And when they reflexed to SMAD4 sequencing, they found a mutation in about 1.4% of patients. So for patients who really meet that strict Curacao criteria, the genetic testing is probably a bit better, so picking up a little bit over 97% of patients. And so when you know someone really meets that strict criteria, then you may want to start with this testing paradigm. For individuals who meet Curacao criteria but had negative testing previously, you just might want to make sure that they have had sequencing of the promoter of ANG. So if their testing was done more than 10 years ago, that may not have occurred. In the last 5 to 10 years, SMAD4 testing became available. And so you might want to check if they really meet that strict criteria, did they really have SMAD4 testing done? And if it's been within the last couple of years, that's when GDF2 testing became available. And so you might want to offer them GDF2 testing. For those patients who do meet the strict criteria for HHT, there are also hypotheses that the remaining 3% or so of patients where a mutation can't be identified in ACVRL1, ANG, or SMAD4, that they have mutations in intronic regions in ANG and ACVRL1, and that could account for the remaining 3% of patients. If someone doesn't meet the Curacao criteria, you might want to consider a panel that has ANG, ACVRL1, SMAD4, GDF2 on that panel. And if they don't meet criteria, you might want to just think about why is it that they don't meet criteria. Is it because they're a child and they haven't yet developed some of the symptoms like telangiectasias and nosebleeds, or do they really not fit into an HHT phenotype? Is it because they're an adult and maybe their vascular lesions aren't characteristic of HHT? Or is it because they only have one symptom? So if they only have one symptom like a brain AVM, you might want to think about doing a testing panel that includes something like P10, RASA1, HHT genes, so not just your typical HHT panel. And as I said, just really thinking about the vascular malformations, are they really telangiectasias? And if they aren't quite characteristic of telangiectasias, you might want to consider prioritizing something like RASA1 or GDF2 over the typical HHT panel. This is a genetic testing algorithm that has been published by the University of Utah group, and they do recommend for a classic HHT phenotype to start with ANG and ACVRL1 and then reflex to SMAD4. And then they also talking about exome or genome sequencing or research enrollment to really try and identify that small percentage of patients that don't have a identified mutation. And it's possible that those could be intronic mutations. And if you have an HHT-like phenotype, they talk about potentially doing an HHT multi-gene panel. And they do include ACVRL1, SMAD4, GDF2, and RASA1 on that panel. And that's also something they say to consider if someone has the classic HHT phenotype. And then again, thinking about exome or genome sequencing or research for patients who have an HHT-like phenotype. So in summary, my recommendations are to apply the Kurosawa criteria and determine, does somebody really meet that strict definition based on those criteria? And if they do, then consider doing ANG and ACVRL1 testing with reflex to SMAD4. And if they don't meet criteria, then ask the question, why is that? Is it because they're a child? Is it because they only meet one criteria? Is it because their cutaneous vascular malformations aren't typical for HHT? And then choose your genetic testing strategy based on the answer to that. I just want to acknowledge our HHT team at Cincinnati Children's. And now I'll turn things over to Felicia.
Thank you, Katie, and thank you, Christy, for the introduction. Good morning, everybody. So first, I'm going to go over some background on HHT, and then I'll present data from our paper that was recently accepted in Human Genome Variation, which provides evidence for adding 2 new genes to HHT panel testing for improved detection rate. Okay, currently most labs screen for mutations in ENG, ACVRL1, and SMAD4 when HHT is suspected. However, recently mutations in GDF2 and RASA1 have been identified in patients with symptoms similar to that of HHT. And RASA1, as Katie mentioned, has classically been shown to cause capillary malformation, arteriovenous malformation syndrome. So HHT is an autosomal dominant vascular disorder that affects approximately 1 in 5 to 10,000 individuals and is caused by mutations in ENG, ACVRL1, and SMAD4. All of these 3 genes function in regulating the transforming growth factor beta or TGF-beta signaling pathway. Approximately 85% of HHT cases are thought to result from mutations in ENG, ACVRL1, and SMAD4. However, no known genetic cause can be attributed to the 15% of clinically suspected cases with no known mutation. When Kurosawa diagnostic criteria are strictly applied, the majority of individuals will have a mutation in either ENG or ACVRL1. However, of the 892 cases that were sent to Ambry Genetics from 2008 to 2014, where HHT was either indicated or suspected, the detection rate for causative mutations in either of those 3 genes was only 47%. And because symptoms of HHT can also be present in individuals who test negative for mutations in ENG, ACVRL1, and SMAD4, this indicates that other genes may be involved or that there is significant overlap of symptoms between vascular disorders. So I'll briefly go over once again the diagnostic criteria, the Kurosawa criteria. So if 3 Kurosawa criteria are met, a definite diagnosis of HHT, and if 2 are met, then it's a possible diagnosis of HHT. So the first one is recurrent and spontaneous nosebleeds, multiple telangiectasias on the skin of the hands, lips, or face, or inside of the nose or mouth, visceral lesions such as arteriovenous malformations or AVMs of the lung, liver, brain, spine, or GI telangiectasia, and a family history with a first-degree relative, such as a brother, sister, or parent with a definite diagnosis of HHT. So I'll briefly go over RASA1. It encodes P120 RAS GPase activating protein, and it's able to negatively regulate the RAS-MAP kinase pathway through its regulation of RAS. It's been implicated in vascular development, and mutations in RASA1 cause capillary malformation, arteriovenous malformation, or CM-AVM. Approximately 30% of cases of CM-AVM also have AVMs of the skin, muscle, bones of the face, ears, thorax, extremities, brain, and spine, similar to that of HHT. So GDF2 encodes growth differentiation factor 2, and it is also known as bone morphogenetic protein 9, or BMP9. GDF2 is also part of the TGF-beta signaling pathway, and it acts to stimulate the pathway through its interaction with the ENG, or endoglin receptors, and ACVRL1. Recently, mutations in the GDF2 gene were reported in patients with symptoms similar to that of HHT, as shown in Wittercheck, Donahue et al. In 2013. So then we asked the question whether ROS1 and GDF2 should be included in HHT panel testing. And we utilized next-generation sequencing to test for mutations in ROS1 and GDF2 in 93 patient samples, which had been clinically suspected to have HHT, but had been previously tested negative for mutations in ENG, ACVRL1, and SMAD4. And within this cohort, 5 individuals met at least 3 of 4 Curacao criteria, 23 met 2, and 65 met 1 or less Curacao criteria. This diagram shows the average depth of sequencing coverage for each exon of ROS1 and GDF2 in each of the 93 samples. And as you can see, coverage was excellent for both GDF2 and ROS1 in all exons. This table shows the variants that were detected in ROS1 and GDF2 in our cohort, who were composed of patients suspected to have HHT. The first one was a missense mutation in ROS1, and it created a cysteine to a cysteine substitution at amino acid 528, and this was predicted to be damaging by polyphen and SIFT. We classified this as likely pathogenic. And this individual met 2 Curacao criteria. This mutation had already been described in the literature in a patient with CM-AVM, and it had a low frequency in population databases, such as ESP. The second novel mutation that was found was in ROS1, and it was a nonsense mutation at amino acid 1015. It was predicted to be damaging, and we classified this as pathogenic. The individual met 2 Curacao criteria, and it was not detected in any population databases. A missense variant in GDF2 was also detected. Polyphen and SIFT were conflicting in that polyphen thought it was predicted it to be benign, and SIFT predicted it to be damaging. We classified it as having unknown significance, and this individual had a definite diagnosis of a Curacao or HHT needing 3 Curacao criteria, and it had a low population frequency in ESP and 1,000 genomes. So this figure shows the NGS data from our study, and it depicts each of the variants, and we also Sanger confirmed each of these variants as shown below in B. So we used 2 independent methods to identify these variants. So now I'm going to briefly go over variant assessment, which was used to classify the variants identified in our study. And I'll be focusing mostly on the structural analysis. And the models that I'll be going through were generated by Bobby Huther and Lester Carter, who are part of our structural biology team here at Ambry Genetics. So first, I'll show you where the mutations were identified. Shown here is the protein structure domain of ROS1, and the substitution at amino acid 528 was identified in the Pleckstrin homology domain, and the nonsense mutation was identified in the gap domain of ROS1. This is the graphical representation of the gap domain of ROS1. And it's shown with its interaction with RAS, which is shown here on the right in gray. So the impact of the identified nonsense mutation at amino acid 1015 would result in loss of the alpha helix, shown here in orange. And this would result in instability, which would be created by exposure of the hydrophobic regions, shown in pink, to the solvent. The majority of the domain is intact. However, instability within the protein would be created by this truncation, and the extent of that instability would determine ROS1's interaction with RAS. The next diagram shows the secondary structure of the Pleckstrin homology domain of ROS1. And shown in green is the amino acid 528 and the cysteine to tyrosine substitution, or the impact of the cysteine to tyrosine substitution. So because you are substituting a smaller, less negatively charged amino acid at this position, which is exposed to the surface, this could result in alteration of the interaction with the protein partner or through ROS1's interaction with its own gap domain. So structural information for GDF2 is limiting. However, when we did a structural analysis of the substitution of the glutamine at amino acid 317 for arginine, we found a possible role in disease. So GDF2 is initially synthesized as an inactive precursor, and it needs to undergo cleavage for maturation. This cleavage is performed by the furin protease, and the substitution of the glutamine at amino acid 317 for an arginine is part of this furin protease recognition sequence. Structural analysis revealed that the furin catalytic domain is largely negatively charged, and this would support a positively charged GDF2 peptide and its basic amino acid arginine. The more neutral glutamine would not contribute to electrostatic stability provided by arginine, and GDF2 binding to furin for cleavage would be decreased. And we predict that the glutamine substitution would decrease the efficiency for furin cleavage, altering levels of mature GDF2 and negatively affecting cellular signaling. So I'll briefly go over the clinical features of the patients where the variants in ROS1 and GDF2 were identified. The cysteine to tyrosine substitution at amino acids 528, the individual had a number of multiple branching telangiectasias on palms, fingers, tongue, and toes. Their nasal mucosa was reddened, and nosebleeds occurred almost daily. They had a family history of nosebleeds that were apparent in the father and son of the patient. The nonsense mutation in ROS1 was identified in an individual that during pregnancy had symptoms similar to those of HHT, including telangiectasias and nosebleeds. Pulmonary findings showed shunting that was suspicious of pulmonary AVMs. However, no pulmonary AVMs were seen after pregnancy. And there was a family history with a father, paternal aunt, and uncle also having telangiectasias. The variant of unknown significance in GDF2 was described in a patient as having a definite diagnosis of HHT. The patient had a history of nosebleeds with several telangiectasias on their fingers, lips, ears, as well as pulmonary AVM. And there was suspicious family history with two sons having frequent nosebleeds, which required cauterization as children, but no AVM. So you can see the clinical features of the patients where these variants were identified were similar to that of HHT. So in conclusion, molecular screening for mutations in GDF2 and ROS1 in individuals suspected of having HHT who tested negative for mutations in ENG, ACVRL1, and SMAD4 was performed by next-generation sequencing. Two variants in ROS1 were identified. One was pathogenic and one was likely pathogenic, and two individuals with a possible diagnosis of HHT. Therefore, the detection rate for causative mutations identified in ROS1 in our cohort was 2.15%. A variant of unknown significance in GDF2 was identified in an individual with a definite diagnosis of HHT, and our results provide evidence for molecular screening of ROS1 and GDF2, which may allow for more accurate diagnosis in patients presenting with symptoms of HHT who also test negative for mutations in ENG, ACVRL1, and SMAD4. And I just want to take a minute to acknowledge Bobby Huser and Lester Carter, who performed the structural analysis, and Tammy Johnson, who performed the variant assessment for the identified variants, and Jennifer Thompson, who worked on the HHT detection rate, and Erin Elliott and Elizabeth Chow for all their informative contributions, and James Gosage for his editing of our manuscript. Thank you.
Thank you so much for both of you guys. That was fantastic. So we do have a number of questions coming in, so feel free to continue to ask those, and we'll get to as many as we can. So we will start with, we had one question for Katie. Due to the potential HHT to affect multiple organ systems, it seems like many different subspecialties of medical providers will interact with these patients. Where do most of your referrals come from in your HHT clinic?
So we really do have a variety of referral patterns. I think because we're a pediatric center, unfortunately, we often have patients who come through our neurosurgery or cerebrovascular clinics and through our interventional radiology clinics because they've had a pulmonary AVM or brain AVM that has bled. And so we're seeing them actually after the fact because that may be the first symptom that they have. But we also do get referrals from just our general genetics clinics, from patients who are referred to our hemangioma and vascular malformations group without realizing that they have HHT, but knowing they have some type of vascular malformation, and then a lot from our adult ENTs.
Great. And we've got another one for Katie. Can you comment on the general awareness of HHT among pediatricians and primary care physicians, and what types of physicians need to be educated more about this disease?
I do think in general HHT is probably under-recognized condition in patients. You know, we talk about patients who meet the strict diagnostic criteria and who have all of these symptoms, but there are probably patients out there whose symptoms don't seem as severe, and so it's just under-recognized in general. So I think there are some pediatricians and primary care physicians, just like for any genetic condition, that have patients that have HHT, have interacted with them and know about HHT. I also think there are probably a lot of physicians and primary care pediatricians that don't know about the condition. So certainly I work at an HHT center. I think everyone should know about HHT, but pediatricians and primary care physicians are going to be some of the first people that are interacting with patients. Other types of physicians that should probably be aware of HHT are ENTs, especially adult ENTs. Dentists in general need to be aware because there's a risk for brain infection in patients who have pulmonary AVM, so they need to be aware of how to take care of these patients. And then any type of patient or any type of physician that we see that's part of a HHT Center of Excellence, so ENTs, interventional radiologists, neurointerventional radiologists, neurosurgeons, geneticists, all of those as well.
Perfect, thank you. And this one is not directed to anyone in particular, but we have one attendee who is asking, what is the incidence and prevalence of HHT in the general population, and are there any racial or gender differences in disease appearance?
So I can talk a little bit about that. I mean, the published prevalence is 1 in 5,000 to 1 in 10,000, although a lot of people think that is underdiagnosed. I think there aren't specifically racial differences, but I do think for people who have darker colored skin, it could be more difficult to identify telangiectasias and other vascular malformations. So it could be more difficult potentially to see if someone meets criteria. And then I mentioned some gender differences, like females are more likely to have GI bleeding than males. You can sometimes see women will say that their nosebleeds seem to be affected by their menstrual cycles, so you might see a change in nosebleed patterns for those women. But overall, you can really see all of the symptoms in males, females, or really any racial group. I'm not sure if anyone else has anything else to comment.
Felicia, did you have anything you'd like to add?
No, I think Katie did a good job of explaining. Thank you.
Okay. Our next question is, how should one approach molecular screening for HHT in an individual with classic HHT who meets at least 3 of the Kurosawa criteria and an individual with an HHT-like phenotype?
So it's recommended for individuals who meet at least 3 of Kurosawa criteria that ENG and ACVRL1 gene sequencing are first performed along with deletion and duplication studies with reflex to SMAD4 gene sequencing and del-dup analysis. For an individual with HHT-like phenotype, it's recommended to use a multi-gene panel and array, which includes all screening for all 5 genes, ENG, ACVRL1, SMAD4, GDF2, and ROSA1. I don't know, Katie, if you have anything more to add.
Usually for us, when we see patients, if they have an HHT-like phenotype, especially just depending on patient's insurance and how much testing is going to be out of pocket for the patient, we try and think about what makes them different from a classic HHT phenotype, and is there any genes that we should think about testing first. So if they really seem like, right, they have an HHT-like phenotype, but it's because we haven't done brain or lung imaging, then we might still just start with the ANG and ACVRL1 because they are still the most common. Or if we really aren't sure, then we might just do a panel, like Felicia mentioned.
Okay. Our next question is capillary malformation AVM syndrome, or CM-AVM, has a clinically distinct phenotype. Why should ROSA1 be included in molecular screening for HHT?
Oh, okay, so upon evaluation by a clinician that has specific expertise in this area, the appearance and location of capillary malformations or telangiectasia as described in CM-AVM are distinguishable from those of HHT. However, the vascular malformations are difficult for some clinicians who lack specific training in this area because they are significantly similar. Furthermore, as we provide information in the current manuscript that was just accepted, and there was another study at the University of Utah found that mutations in ROSA1 were indeed identified in individuals with symptoms similar to HHT.
Great, thank you. Again, please keep questions coming. We do have a couple more to get to, but we will have time. So if you have any questions at all, please feel free to type those in the Q&A box. The next question is, for patients who do not meet full criteria, is there any workup for bleeding disorders such as von Willebrand's disease?
As far as I know, there aren't any published guidelines about the workup for bleeding disorders in patients who don't meet full criteria. For us, when we're seeing patients, it's usually more on a patient-by-patient basis as to whether or not our physicians would recommend doing any type of workup for bleeding disorders.
Okay, and we have another question. This person is curious about how the use of genetic testing, since it has become more common, has affected using the Kurosawa criteria in clinic.
I'm sure that anytime someone has symptoms that are reminiscent of HHT, I think it's likely now that we can use genetic testing that people order genetic testing, even if people don't meet the strict criteria. And really, it's important to know if people have HHT because there are management guidelines that we need to follow for them if they have it. And even if people don't meet the full strict criteria, we're likely going to proceed to some type of genetic testing for them anyways. Even when they do meet the strict criteria, we need to go ahead with genetic testing for their family members. So I think genetic testing is going to be an integral part of diagnosis.
Thank you. And we do have a question on whether there's any type of a genotype-phenotype correlation that is understood currently.
So in general, ANG mutations are thought to have an earlier onset for things like nosebleeds and telangiectasias, more likely to have pulmonary and brain AVMs, whereas ACVRL1 mutations are really thought to have a more of a chance for liver AVMs and probably a later onset for nosebleeds and telangiectasias. But those aren't definite. It's not that everyone with an ACVRL1 mutation won't have a nosebleed onset until later, and everyone with an ANG mutation will have nosebleed onset in childhood. Those are just kind of generalizations that we see. Certainly for SMAD4, people have juvenile polyposis and the cancer risks associated with those, and that's a very strong genotype-phenotype correlation.
Thank you. Are there any other questions? Please go ahead and type those in the Q&A box. I'll give you just a minute just to make sure we're not missing any. And in the meantime, just remember, if you are a genetic counselor who is claiming CEUs, when you click out of the WebEx presentation, you will automatically get a survey that will pop up, and so you must complete the survey by the end of the day today in order to receive those CEUs, and you will be receiving an email once we get that submitted. Okay, looks like we have no more questions. So thanks again for joining us today. That survey will pop up. Go ahead and take that. If you have any concerns or you're not able to see that link, shoot us an email and we can get that to you. And also remember that Ambry does continue to offer educational webinars, so please check back at embrygen.com to see what webinars are being added and to register for these events. So thank you again to our speakers and our attendees, and have a great day.